सर मैं जहाँ पर मैं बस फंस गई सर, कहीं पर मैं पहुंच नहीं पाई।
आप कितनी देर तक घर पहुंचेंगे?
सर मेरे को आधा घंटा लगेगा सर पहुंचने में।
बेटा मैं आपको होस्ट बना रहा हूँ। आई एम बिजी विद
ठीक है
सम
सर।
अदर वर्क, यू प्लीज मैनेज नाउ, ओके?
ठीक है सर। ठीक
आई एम लिविंग द मीटिंग एंड आई
ठीक है।
गॉट सम अदर वर्क, आई मेड यू को होस्ट, ओके?
ठीक है सर। ठीक है
यू आर
सर।
नाउ
थैंक।
होस्ट टू मैनेज द शो।
ठीक है सर। अरे यार, पता है भाई हूँ।
किसी और को बनाना हो तो यहाँ जा।
हाँ पापा, हम आधे घंटे में पहुंच जाएंगे, ठीक है? हाँ हाँ हाँ, निकल गए ओके बाय।
पार्टिसिपेंट्स पे क्लिक करेंगे ना, तो क्लिक कर और मैं एक होस्ट कर दिया, ठीक है? जैसे क्लोज करा
हट जाओ जस्ट।
आवाज आ रही है? आवाज ही नहीं आ रही।
सर उस दिन भी दिक्कत आ रही थी ना आवाज में।
देखते हैं क्या। नहीं, कोई बोल रही थी कुछ, गाना शाना चला के दिखता है। आवाज हमारी है कि नहीं?
Do you want to create another source of income?
वही ठीक है।
बंद रहना चाहिए।
Good evening, all.
Good evening, Dr. Sethi.
Evening, sir.
Good evening. Good evening. Actually, I have to join Gunning Council meeting at 6:15 p.m. Hello, Dr. Kirti. How are you?
I'm good. How are you, Dr. Sethi?
Sorry, I will be missing the meeting, and you will be carrying on because I have to attend the GC meeting, which is scheduled at 6:15 p.m. So, best wishes for today's CME. Excellent work done by the President, Madam, and Secretary Vishal. And thanks to the eminent faculty, those who are delivering the talk today.
Thank you, sir.
Thank you.
Good evening, everyone. My name is Dr. Vasudha Govil, and I'm working as Associate Professor in the Department of Anesthesia, PGIMS Rohtak. And today I welcome you all for this academic feast. And we are really thankful to Rsacp for organizing this academic extravaganza very frequently, which helps us in increasing our knowledge regarding our day-to-day work. So it is my great honor to welcome our esteemed chairpersons, Dr. S.K. Singhal, HOD and Senior Professor, Department of Anesthesia, PGIMS Rohtak, Dr. Qrp, Professor, Department PGIMS, Department of Anesthesia, PGIMS Rohtak, and Dr. Sunil Sethi, Consultant, Senior Consultant, Karnal. And now I would like Dr. Qrp to start with our first session and introduce our speakers for the first session. Over to you, ma'am. Qrp, ma'am.
Hello, good evening, everyone. Our speaker of the day is Dr. Vineet. He's an assistant professor in the Department of Anesthesia, and he would be discussing anesthesia for TURP. Over to you, Dr. Vineet. Please start the proceedings.
Hello, good evening, ma'am. Very good evening to all the respected faculty members. I'm Dr. Vineet, Assistant Professor, Department of Anesthesia, PGIMS Rohtak. Today's topic for academic webinars is 2022.
Hello.
Host has disabled the screen sharing. Can you please enable it, Vasudha? Screen sharing is disabled.
Wait a minute. Screen. Just a minute, Vineet.
Okay.
Can you do it now, Vineet?
Yeah, I can. Is it visible? Is it visible, madam?
Yes, it is visible.
Yes, it's very much visible.
A very good evening to all the respected faculty members. I'm Dr. Vineet, Assistant Professor, Department of Anesthesia, PGIMS Rohtak. Today's topic for academic webinar series 2022 is geriatric anesthetic implications for TURP surgeries. What are we expecting to learn in this academic session? First of all, pre-operative assessment and optimization. Then what are the physiological changes in geriatric patients and its anesthetic implications? What is the anesthetic technique of choice in TURP patients? And what is the Trb syndrome and its management? First of all, regarding the relevant anatomy of the prostate. Prostate, there are 4 histological zones known as McNeil zones. The central zone, 2 peripheral zones, and transition zone. The transition zone surrounds the urethra, which keeps growing, which leads to obstructive symptoms. That leads to benign prostatic hyperplasia. Normal prostatic tissue becomes compressed against the capsule and forms the surgical capsule. TURP surgery is one of the most common surgery done in geriatric patients. And what is this surgical procedure? TURP is performed by inserting a resectoscope through urethra. Prostatic tissue is dissected into pieces with an electrically powered cutting and coagulating metal loop. Then pieces washed out by irrigation solution. The aim is to preserve the prostatic capsule. If capsule is violated, then large amount of irrigation fluid is absorbed in the circulation in the periprostatic and retroperitoneal spaces. Now, what are the concerns in the geriatric patients? First of all, they have the multiple comorbidities. And now we'll talk about the physiological changes. First of all, there is changes in autonomic nervous and cellular homeostasis, leading to temperature alteration, blood volume, and endocrine changes. There is the reduction in organic mass of main organs like brain, liver, kidney, bones, and muscles. There is a reduction in the organic functional reserve of lungs and heart. Almost all systems are affected in the geriatric age group. Going to cardiovascular changes, There is a fibrosis in the myocardium and conducting systems, leading to arrhythmia and heart block. These patients are poorly tolerate peri-op fluids, leading to because of their diastolic dysfunction. There is loss of SA node cells, leading to slowed conduction, decreased response to catecholamines. There is calcification of heart walls, and there is a decrease in cardiac output. Also, there is reduced arterial compliance and loss of elasticity because of the underlying atherosclerosis. There is exaggerated drop in blood pressure during induction of general anesthesia, and a prolonged circulation time delays the onset of intravenous drugs. So we have to give the titrated doses. But there is speeds induction with inhalation agents as their minimum alveolar concentration is decreased. They also have the less ability to respond to hypovolemia, hypotension, hypoxia. Now changing in respiratory system, there is the reduced lung and chest wall compliance, reduced alveolar surface area, leading to reduced diffusion capacity. The closing capacity is higher as compared to functional reserve capacity, leading to early closure of small airways. There is an increase in physiological dead space, decreased ciliary function, increased ventilation perfusion mismatch, hence lower arterial oxygen levels. And also there is reduced laryngeal sensitivity, leading to blunted cough reflex, and there is a risk of silent aspiration. Going on to renal changes, there is a gradual decrease in number of functioning nephrons. Renal blood flow decreases, GFR decreases. There is no change in the serum creatinine with advanced age. What are the implications of these renal changes? There is decrease the renal excretion of anesthetic drugs, especially neostigmine metabolites of morphine and pethidine. Benzodiazepines are also affected. Their higher free fraction levels of benzodiazepines, increased volume of distribution and decreased protein binding of thiopentone. And we have to avoid the longer acting neuromuscular blocking agents, especially pancuronium. Renal insufficiency, dehydration and renal failure are common in elderly. So we have to encourage clear fluid intake till 2 hours before anesthesia, have to follow the proper NPO status before surgery. And early intake of liquids in post-op period. Now moving on to skin and musculoskeletal system. There is loss of epidermis. So elderly patients are prone for decubitus ulcers, less elasticity, wrinkling and sagging of the dermis, reduced muscle mass, edentulous, osteoarthritis, osteoporosis, and the presence of limb and spine deformities. These deformities can lead to implication like fragility of skin, will lead to difficulty cannulation, trauma from ECG electrodes, especially when we remove them. Different surgical position we have to handle with care. So to avoid any nerve injury, we have to pad the pressure points. We have to take care to prevent any fall during pre and post-op period. And there is a limited extension, so it can lead to difficult intubation. There is also alteration in hypothalamic temperature regulation centers, which can lead to hypothermia. The comorbidity include diabetes also, beta adrenergic desensitization, and also the plasma cholesterol levels. Into neurological changes, there is progressive loss of neurons, especially in frontal lobes. Autonomic dysfunction leading to postural hypotension, impaired thermoregulation, urinary retention. There is increased threshold for nearly all sensory modalities. There is extensive spread of epidural dose with spread with same bolus volume administered to the patient in epidural, as there is decreased space and decreased compliance of the epidural space. And moving on to post-operative cognitive dysfunction. There is increase in incidence of cognitive impairment, especially in first week post-op period. The short-term memory is most affected. There is the positive effect of continued physical and intellectual activity. The etiology is multifactorial, especially the effects of the drug due to pain, any underlying dysfunction, because of hypothermia, any metabolic disturbances, and any intraoperative arterial emboli, especially during plastic joint replacements, any cardiac surgeries. And what is the difference between post-operative cognitive disorder or post-operative delirium? Post-operative cognitive disorder often observed weeks after surgery. It persists for longer time. There is chances of increased mortality, which may lead to dementia. Whereas a delirium characterizes the acute, this is the acute alteration in the mental status. It represents acute brain dysfunction. It usually sets in 24 to 72 hours post-operative period. There is a reversible course of fluctuating severity. What are the anesthetic concerns in geriatric patients? First of all, there is difficulty in communication and cooperation. Chances of POCD or post-operative delirium are higher. There is sensitivity to centrally acting anticholinergic agents. The minimum alveolar concentration for inhalation agents is reduced, leading to faster inhalation induction. The reduced dose requirement for anesthetic agents, and we have to maintain normothermia using warm solution, warm blankets, and we have to keep the OT temperature optimum. So moving on to preoperative evaluation of geriatric patient posted for Qrp surgery. First, we have to take the complete history, physical examination, then laboratory investigation, and a tailor-made anesthesia plan according to the patient status and the surgery. Incomplete medical history, the routine history, the present history, past history, any medication, any allergy to drug. We have to also see the malnutrition, immobility, and the hydration status, dentures, any pacemaker, any history of any joint replacement. Especially for physical examination, we have to look for the signs of the difficult intubation and difficult ventilation, and the spine, difficult IV line, wait for BMI and drugs compliance. What are the investigation we are going to have? Complete hemogram, renal function test, coagulation profile, chest X-ray ECG, routine urine and microscopy, as there is a risk of UTI in a patient in benign prostatic hyperplasia, viral markers, blood grouping, any special investigation for any cardiovascular compromise, 2D echography, and a BG, blood gas analysis, and as per need. Now, elderly patients are vulnerable and particularly sensitive to the stress of trauma, hospitalization, surgery, and anesthesia. First of all, we have to understand the old age physiology and preoperative management and their coexisting disorders. There should be meticulous preoperative assessment of organ function and reserve, careful drug selection and dosage titration, careful fluid therapy, the choice between regional anesthesia and general anesthesia, proper psychological preparation and management, and good post-operative pain control. So choice of anesthesia depends on the type of operation and the condition of the patient. What are the pros of general anesthesia? These general anesthesia usually in patients who are unable to lie supine for any length of time, for those with significant cardiovascular disease. With regional anesthesia,
88.
With a single low dose anesthetic requirement, patient is awake and mentation can be assessed. There is early recognition of complications, minimum respiratory and physiological changes, peripheral vasodilation leading to less chances of circulatory overload, more venous pressure at the sinuses, stop analgesia, good surgical access, and there is lower incidence of deep vein thrombosis. In terms of general anesthesia, there is a delay in diagnosis of complications. Position also increases the risk of creation. Most of anesthesia will be needed. In regional anesthesia, anesthesia does not prevent penile erection, which can interfere with sleep. What are the complications related to the Qrp surgery? Intraoperating, there are chances of hypothermia, blood loss, myocardial ischemia, rupture of the prostatic capsule, Qrp syndrome. In post-operative period, there is bladder spark, post-op bleeding, chances of myocardial ischemia, and Qrp syndrome. Now moving on to Qrp syndrome. Qrp syndrome is a clinical diagnosis based on the symptoms and signs caused by excessive absorption of irrigation fluid into the circulation. It can set within 15 minutes to 24 hours post-surgery. It mostly occurs due to acute changes in the intravascular volume, plasma sodium concentration, and the osmolality level. This may be attributed due to the direct effects of the irrigation fluid used, such as glycine and its metabolites. The effect of the Qrp syndrome are proportional to the volume of the irrigation solution absorbed. What are the factors which influence absorption of irrigation fluid? First of all, monitoring of the perioperative fluid balance is most important. Delivering irrigation fluid at the lowest required pressure, height of the fluid, IV stand should be less than 70 centimeters. If patient is hypovolemic or hypotensive, we should use vasopressor to maintain blood pressure. Duration of the surgery should not be more than 1 hour, as there is 20 to 30 ml fluid is absorbed per minute during surgery. We have to avoid the large blood loss, because there is around 2.5 to 4.6 ml of blood loss per minute of the surgery. We have to watch out for the capsular bladder perforation, and should we use use of laser excision or bipolar electrode excision. Smoking increases the chance of large-scale fluid absorption during Qrp surgery. And when we talk about the ideal irrigation fluid, we talk about it should be transparent, isotonic, electrically non-conductive, non-hemolytic, not metabolized, non-toxic, inexpensive, and should be sterile. But no such fluid exists. The most commonly used fluid for irrigation is 1.5% glycine. The osmolality of 1.5% glycine is 220 milliosmol per kg. Another fluid can be used, mannitol 5%, sorbitol 3.5%. And how do Qrp syndrome present? The changes in cardiovascular system, bradycardia, hypertension or hypotension, chest pain, raised CVP, ECG changes, pulmonary edema, congestive heart failure, and cardiac arrest. In central nervous system, there is apprehension, restlessness, disorientation, nausea, visual disturbance, confusion, coma, and seizures. In Qrp syndrome, the faster the fall of serum sodium levels, the more toxic symptoms will be there. Usually symptoms arrive when presents when serum sodium level drops to 120 milliequivalent per liter or drop to level 20 to 30 from the base level. CNS effects with serum sodium less than 120 are confusion and restlessness with ECG changes of wide QRS complexes. At serum sodium level 115 milligram per liter, there is nausea, somnolence, leading to wide QRS complexes. And at the level of 110 serum sodium level, there are seizures, coma, leading to ventricular tachycardia and fibrillation. Now, what is the management of the Qrp syndrome? Management is basically symptomatic. We have to watch out for the airway, breathing, and circulation. In severe Qrp syndrome, first of all, we have to stop the surgery as quickly as possible and give 100% oxygen. We have to secure the airway, breathing. In circulation, we have to give vasopressor or inotropes. If seizures are there, we have to control seizures with diazepam or lorazepam, or we have to consider magnesium. And we have to take the investigation. We have to take blood for serum sodium level, hemogram, osmolality. If there is pulmonary edema, we have to give diuretic, example, furosemide 40 milligram, mannitol 20%, and we have to monitor the vitals, and if possible, we have to insert the arterial or CVP lines. If serum sodium is less than 120 millimole or severe symptoms, we have to give 3% NaCl according to body weight. Our aim to correct serum sodium is by 1 millimole per liter per hour until some symptoms improve. We have to watch out for further deterioration or continue vital monitoring with serum sodium level monitoring, hemoglobin, and osmolality. Our aim is to increase the extracellular fluid tonicity to shift the water from ICF to EC, intracellular fluid to extracellular fluid, which ameliorates cerebral edema. We use hypertonic saline 3% in those with normal renal function. Hemofiltration is the choice if the patient has chronic liver failure. Soda bile can be used if hypertonic saline is unavailable. Our main aim is clinical improvement, not the correction of sodium to normal levels. How do we correct sodium? First of all, we have to calculate the sodium deficit. How we calculate it? The total body water multiply the target level of the serum sodium, subtracting the level serum sodium of plasma level of the patient. The total body water is approximately 50% of body weight in females and 60% is male. Then we'll calculate sodium deficit with this formula. Then if we are using 0.9% normal saline, which contains 154 milliequivalent per liter serum sodium, then this patient will receive around 3 liters of normal saline. Then for the correction of serum sodium, we have to give 0.5 milliequivalent per liter per hour. We don't have to overcorrect the serum sodium. Our main is just clinical improvement. Now, another complication is in Trb surgery is glycine toxicity, which is the irrigation fluid, which is the most commonly used. Glycine is the second most widespread amino acid. It is the important inhibitory neurotransmitter in the CNS and the retina. Toxicity may cause prickling sensation, facial warmth, headache, nausea, malaise, retinal dysfunction, including transient blindness. May directly provoke myocardial depression. It potentiates the NMD receptor, which may precipitate convulsions and can lead to encephalopathy. The higher serum ammonia levels also can lead to neurological disturbance. The reassurance is the most important part of this treatment. Another complication is the hemorrhage. It is difficult to quantify the blood loss during the Qrp surgery due to dilation, the use of irrigation fluid. And there is also tachycardia and hypotension is masked by the bradycardia and hypertension of overhydration. There is a roughly 10 to 15 ml blood loss per gram of resected prostatic tissue. The cause of increased blood loss during Qrp is hypervolemia leading to circulatory overload, and the positioning in lithotomy positioning, there is stasis of the blood in the pelvic region. And third one is the urokinase, which is released from the resected prostatic tissue, which activates the plasminogen, which delays post-op bleeding, which leads to delayed post-op bleeding and oozing from the prostatic tissue. And the treatment is the adequate blood transfusion, tranexamic acid, and the fibrinogen. What are the take-home points? First of all, old age is not a disease. Qrp syndrome can cause a wide variety of symptoms. In general anesthesia, many of the signs and symptoms may be masked. Regional anesthesia aids in the early diagnosis and the treatment of the Qrp syndrome. The hyponatremia must be treated aggressively to avoid intravascular hemolysis if serum sodium concentration is below 110 millimole per liter. And the time factor is very important. Thank you, ma'am.
Thank you, Dr. Vineet, for delivering such a lovely talk. In concisely, you have dealt with the various points of managing QRP. Dr. Vineet, what is your final view of choice of okay, sir has also joined. Good evening, sir.
Good evening.
Good evening. Good evening. Continue, please. Continue.
So what is your final choice of anesthesia for the viewers?
My take in Erp surgery is in a patient with a large prostate, we should always use normal saline as a fluid of choice, and regional anesthesia is my preferred technique, as we can diagnose early the Trb syndrome signs and a glycine toxicity.
Thank you, Dr. Vineet.
So I think the topic has been nicely covered, and within stipulated time, he has tried to give insight of the QRP. Say some cases if they require general anesthesia, and how you will differentiate early that the patient is getting into TRP.
Yeah. Sir, you're asking about TRP syndrome, sir.
Under general anesthesia, if this thing happens.
Yeah, if this happens, first of all, sir, if there's any blood loss, then we can we can watch out for the vitals lead to the which is tachycardia and hypotension. And in Qrp syndrome, sir, there are chances of pulmonary edema. So you can watch out. There are pressure monitoring, airway pressure monitoring.
Yeah, that would be in fact initial picture would be something like desaturation and the getting retained into pulmonary. Yeah, that would be the not the early picture as we see in the spinal patient getting irritable, having mental clouding,
yes,
hyponatremia. Little differences would be there if the patient is under anesthesia.
There will be in GA there will rise in BP followed by a prolonged fall in blood pressure. There will be ECG changes. There will be chances of respiratory arrest, as you have mentioned, sir, and the delayed recovery from general anesthesia.
Okay, thank you very much.
Thank you, Dr. Vineet, for such an informative talk on the anesthesia for TURP surgeries. Thank you, Dr. Suresh Singhal, our departmental head and senior professor, for increasing our knowledge on this topic, and Dr. Qrp, our professor, for encouraging Dr. Vineet and increasing our knowledge on this topic. Thank you so much. Now I would like Dr. Qrp to introduce our second speaker for the day.
Second speaker for the day is Dr. Mamta Jain. She's an associate professor in the Department of Anesthesia, PGIMS Rohtak. Her talk today would be Anesthesia for Pcnl. Dr. Mamta, please.
Good evening, everyone. I just want to just confirm that my slides are visible. Like,
no, Dr. Mamta. I think your screen sharing. I think we are still sharing Dr. Vineet's screen.
oh, okay.
I think Dr. Vineet has to stop sharing his screen.
Yes, okay.
Dr. Vineet, to please
Yes.
respond.
Yes, just a minute. Just a minute.
Hello.
Yeah, कर दिया. Make. Yes. Done. Dr. Mamta.
Yes, sir.
Please.
Yeah, thank you, Vineet.
Okay. Share your slides now.
Share screen. Okay. This will stop other screen sharing. Do you want to continue? Yes.
Yeah, Dr. Mamta, we can see your screen.
Okay, thank you. Yeah, good evening, everyone, respected teachers and my dear colleagues. My topic of this session is anesthesia for percutaneous nephrolithotomy. To start with, as we know that the incidence and prevalence of renal calculi is increasing globally, and it has been seen in all age groups, sex and race. Like initially, it was seen that the renal calculi was more common in males, and now, but it is there is no sex preference is now seen nowadays. And also it has been found that the location is also, earlier it was the lower respiratory tract, lower ureteric tract was involved. Nowadays it is moving upward, and the upper urinary tract is also commonly seen involved in the case of renal calculi. The main risk factors for this increased incidence which has been observed is because of the change in the dietary habits of the people, and also the global warming is seem to have a main impact to increase this incidence of renal calculi. Like the patient, like people who are they are taking more of animal proteins and diet which is high in oxalate and low in calcium. These are the risk factors which increase the chances of renal calculi. Also high BMI and obese patients, like diabetic patients, and it is commonly seen in this kind of patients. So the most common initial management for the diagnosed case of renal calculi is conservative management. But once the conservative management fails, or the size of the stone or the location of the stone is that we require to go for surgical manipulation, the oldest method was the open nephrolithotomy. But nowadays, many minimally invasive techniques are used, which decreases the trauma associated with the surgery, thereby minimizes the morbidity and decreases the analgesic requirement in the post-op, and decreases also at the same time, so they shorten the hospitalization. But these newer minimally invasive techniques require a lot of surgical expertise, and definitely the newer gadgets and instruments are required for these minimally invasive surgeries. So what are the different minimal invasive surgeries that are available for renal calculi? And the choice of that technique which will be used for the renal calculi depend upon the location of the stone, the size of the stone, composition of the stone, and the presence or absence of the anatomical abnormalities in the pelvic calyceal system. First of all, this is a RIRS. This is the retrograde intrarenal surgery. In this, the stones which are present in the lower calyceal system and are of the size around 1 to 2 centimeter, they can be removed with using this technique. Another is the ESWL. ESWL is extracorporeal shockwave lithotripsy. In this technique, the stones which are up to 2 centimeters in size in the upper calcium systems, and then in the lower calcium system up to 1 centimeter size stone. And stones which have a hardness of less than 1000 Hounsfield unit, which is which are like calculated on the CT scan only. These type of stones can be removed using this ESW technique. And there should be no distal obstruction in the when we are planning to remove the stone using the ESWL. Another technique is the Pcnl. In this technique, the large stones more than 2 centimeters in size and stones which are hard, like more than 1000 Hounsfield unit, and the bigger stones, staghorn calculi, and stones which are present in it kidney where the there is anatomical abnormalities, distal tract obstruction is there, and lower pole stones and the cystine stones, these are removed using the Pcnl technique. This is a percutaneous nephrolithotomy. Now we will discuss this percutaneous nephrolithotomy technique in detail. It was first introduced by von Sturm and Johannesson in 1976. This is a combination of 2 words, PC plus NL. PC is percutaneous nephrolithotomy, the removal of the renal calculi through a nephrostomy tract. It's a minimally invasive technique. In this technique, it provides a direct approach to the calculi of the stone, to the calculi within the kidney, and thereby it prevents the trauma to the surrounding structures and thereby decreasing the post-op morbidity and the pain. Before planning for any type of minimally invasive surgery, we should also know what are the contraindications for that surgery. So the main contraindication for Pcnl are pregnant patient, patient having active urinary tract infection, patient having bleeding disorders, and patient with non-functional kidney. So before proceeding for Pcnl, if the kidney function shows it is a non-functional kidney, we should never plan for the Pcnl in such a patient. Now coming to the technique of Pcnl, there are 2 techniques. One is the standard Pcnl and another was in the mini Pcnl. In the standard Pcnl, normally a patient is in prone position. That is a most common position which is used for Pcnl. Over the skin overlying the kidney, we make a small incision, and through that incision, we go through to the kidney, and through that the guide wire is first access puncture is made through 18 gauge cannula, and through that cannula we reach the desired calyceal system, where we put a guide wire, and over that guide wire different size of dilators are placed serially to dilate that tract from the skin to this calyceal system. And after going to the different the sizes of dilators, finally a sheet is placed through that tract, and through that sheet we place a nephroscope, rigid nephroscope, through which the procedure is done. If the stone size is small, it is removed using a Dormier basket. If the stone is large, then we will break the stone through this nephroscope, passing through the different lithotripses are used to break the stones, and this is the standard procedure which you use for the Pcnl. At the end of the procedure, when the stone is removed, we will keep a nephrostomy tube here that will remain till the patient is discharged from the hospital. And in the mini Pcnl, the main difference is the size of the nephroscope which are used. We use miniature nephroscopes are used nowadays. That is to decrease the pain and the post-op complications. But through this mini Pcnl, it has been seen that a size of stone around 1 to 2.5 centimeter size of stones can be removed in 99% of the cases. But for bigger stones, we need to go for the standard Pcnl. So for any surgery, definitely being an anesthetist, we should know the initial steps of surgery, so that accordingly we can plan at what stage of surgery, what problem will be there, and different anesthetic concern for that surgery to plan the anesthesia accordingly. So anesthetic concerns during Pcnl surgery depend upon the patient renal functioning. If it is deranged, we have to plan the accordingly. And as I have already told, if the functioning is there, the kidney is non-functional, and in the DTDPA scan, if you come to know that the functioning is not there, so we should not go for Pcnl. Definitely we go for nephrectomy in that case. And if deranged renal functioning, accordingly we have to manage our anesthesia plan and drugs accordingly. And in Pcnl, different positionings are used, like lithotomy position, prone position, supine, and lateral position. So every position has its own physiological considerations that should be bear in mind, and accordingly we should plan the anesthesia. And depending on type of the patient and the position of the surgery, we can plan the anesthesia. Patient can be, this Pcnl can be done under general anesthesia, regional anesthesia, or under the monitored anesthesia care. Also, although it is a minimal invasive surgery, there are surgical complications which are there in Pcnl. And being an anesthetist, we should know what are the complications and how to diagnose them early. And definitely we should have all the equipments ready for to manage that complication if it is arise in the intraoperative period. And again, before proceeding for surgery for Pcnl, always rule out active infection, urinary tract infection before proceeding for surgery, because among the most common cause of morbidity and mortality, the septicemia leading to the multi-organ failure is the important cause. So infection should be controlled pre-operatively before proceeding for surgery. So now we'll discuss the different positioning and their anesthetic implications one by one. First, lithotomy position. In this position, as we know that the hips are flexed around 80 to 100 degree and from the trunk, and then the legs are abducted around 30 to 45 degree from the midline. For this, to make this position, we require at least 2 assistants, so that we can do the positioning in a coordinated manner. Both the legs should be raised simultaneously, and brought to the flexion should be done at the same time to avoid the torsion at the lumbar spine. Both the legs should be raised together, flexed from the hip and then the knee simultaneously. Then after the surgery also, the patient must be returned to the spine position in a coordinated manner. And for that, the legs should be brought in midline, holding them simultaneously, and knees should be brought midline, and legs should be slowly straightened and lowered on the operating room table. So what are the different anesthetic concerns which arise during this position? When we raise the legs, we see that the preload will increase, and this increase in preload will initially cause a decrease in the cardiac output, and increase in the central venous pressure, and intracranial pressure rise also seen. This is very well tolerated by healthy patients, but in patients with we have compromised cardiovascular system or patient with raised ICP, this may cause problems, so that should be kept in mind. Also, when we make the lithotomy position, the abdominal viscera will displace the diaphragm stapler, which will decrease the FRC, resulting in a decreased tidal volume. On that, this rise in intrathoracic pressure or decrease in the lung compliance is more in case of obese patient and patient who have large abdominal mass. So that should be kept in mind. Also, in patient who have previously in the pre-op, if they say they have back pain and they have back problems, that in this position, the normal lordotic curvature of the lumbar spine is lost while making this position, and that may aggravate the low back pain in post-operative period for this patient. So the best comfortable position which the patient can make in the awake position, that should be made in this patient. Another important concern is when we raise the leg above the heart level, there is a decrease in the perfusion pressure of the legs. And it has been observed that there is around 0.78 millimeter decrease in perfusion pressure for every 1 centimeter rise in height of the leg above the right atrium. So if it is height is more, then the perfusion pressure might be low at the level of tissue, these legs, and that can result in the compartment syndrome postoperatively. So the perfusion should be well maintained in the legs while making this position. Different nerves which can be injured in this position are femoral nerve and obturator nerve while flexing the thigh at the trunk. So this flexion should not be more than 100 degree. And peroneal nerve and the saphenous nerve, peroneal nerve can be compressed at the knee level and the saphenous nerve at the ankle. So proper padding should be done while making this position for ureteroscopy. Another important concern is you can see that while making this position, if the fingers are not protected properly, they may get trapped when you at the end of the procedure, when you straighten this lower section of the bed, they may get trapped between the 2 parts of the table. So this should be kept in mind and taken care of while repositioning the patient from lithotomy to supine position. Another important position which is used during Pcnl is prone position. And this is the traditional, during the more traditional approach, this is the most favored position by the urologist, as it provides a large surface area and direct approach to the kidney for Pcnl surgery. during this position, the upper lobe puncture is very easy. So this is the why they want to get an upper pole puncture, because through the upper pole puncture we can assess, move down the kidney, and from the same puncture point we can like go through all the kidney poles and all the calcium system, and so the single puncture we can remove the multiple stones. And another is we can also improve this position by making a prone flex position, in which we just flex the spine at the level of waist around 30 to 40 degree, so that the working space will be increased for the surgeon. And in that position, the space will be increased, and the puncture, that is the supra 10th puncture, like 11th rib puncture will become a this 12th rib puncture will become a 11th rib puncture will become a 12th. The space will increase, and the chances of higher puncture without injuring the lung will improve. So in prone position, what are the different physiological concerns? Like as in supine position, if the legs are in plane with the torso, the hemodynamic reserve is well contained in prone position. And for pulmonary function, as we all know that in prone position, definitely there is a better ventilation perfusion match in prone position. So that is also not a problem. And definitely we need to pad all the pressure points during when we make the patient prone. And for the arms, we can keep the arms by the side in neutral position, or we can abduct the arms at the shoulder joint and flex the arms at the elbow, making a Superman position, just to prevent the overstretching of the brachial plexus injury. That arm should not, abduction of the arm shoulder should not be more than 90 degrees. And when this prone position, Pcnl is done in prone position in general anesthesia, we normally intubate the patient and induce the patient on stretcher. And after fixing the tube properly to prevent the dislodgement by the, like in prone position, if the saliva will drool and that it will loosen the tape, so that prevent this dislodgement, proper fixing of the tube should be done. And for making the position patient prone from supine to prone position, we require at least 4 to 5 staff members to turn the patient in a coordinated manner. The neck should be maintained. All the monitoring need to be disconnected while positioning the patient to prevent any dislodgement of the lines and the cannula and drip line. Once we made the position patient prone, the full monitoring should be reinstituted as soon as possible to decrease this window of without monitoring window should be of small period as much as we can do. Also, the ET position should be rechecked. Once we make the position prone, the ET position should be rechecked after making the patient prone. And the most important concern while making the patient prone is to prevent the abdomen wall compression, because if the abdomen is not free, then the diaphragm will, the content of the abdomen will push the diaphragm up, and it will decrease the FRC, and definitely the lung compliance will decrease and the ventilation will become difficult. And at the same time, if the abdominal compression is there, hemodynamically also the venous return will decrease and the patient will become hemodynamically unstable. So to prevent both hemodynamic and the respiratory compromise, the abdominal wall should be free. So the main point is, in prone position, we should always check for the abdomen. It should be free handing. There should be no compression or direct touching of the abdomen with the operating room table. This is the prone flex position. As we see, we make a flexion at the wrist waist. So this working surface area will for the surgeon will increase. Now coming to what are the complication of the prone position? Definitely in the prone position, there are while making the patient prone from supine position, there is chances of accidental extubation, and in prone position, kinging of the endotracheal tube can be there. So proper fixing should be done, and reinforced tube should be used when the Pcnl is done in prone position. And Bostel position, we should always check for the free movement of the abdomen after positioning the patient properly. Torsion of the neck should be avoided, because over hyperflexion of the neck, there will be venous return will be decreased from the head and neck area, and that will cause a facial edema, airway edema, and ocular edema. Also, during the surgery, we should always check for any pressure on the eyeball, because if their pressure is there on the eyeball, the perfusion, if it is, and that pressure is more than the mean arterial pressure, so there can be compromised perfusion of the optic nerve, which can lead to the blindness in the postoperative period. All the pressure points like pinna and in the case of female, breast should be padded and prevented from compression. Breast should be kept in the midline, like middly, pushed middly, and to prevent any compression from the arm should be abducted and brought upward. As I already said, we can keep the arm by the side of the patient in the neutral position, or they can be abducted and flexed at the elbow, not more than 90 degrees, to prevent the brachial plexus injury. All the pressure points should be padded properly. The other position which is used in the for Pcnl is lateral decubitus position. This position is mostly preferred in case of obese patients with high BMI, like more than 50 BMI, and patient with spine deformities, which with the patient who cannot lie supine or prone also. And this position by the surgeon who usually do laparoscopic nephrectomy and all that, they also prefer this position for Pcnl. In this position, the main point is we should keep the neck in line with the spine and prevent the torsion of the neck, because over torsion of the neck definitely will lead to the compromised stretching of the brachial plexus also, and brachial plexus injury can be there in the post-op. Axillary roll should be placed not under the axilla, just below the axilla, to prevent any compression of the this axillary structures. And to prevent, to monitor that axillary compression intra-op, we should use that pulse oximeter in that dependent limb while using this position. And the main problem with using this lateral position is that for the first assess, we use normally the fluoroscopy is used for the first assess puncture in the case of Pcnl, and in this position that C-arm, use of C-arm is very difficult for first access, so you may require to go for like triangulation of the fluoroscopy, or may go for the ultrasound guided first access puncture. So these are the concerns which are there in lateral position, and this is the lateral flex position. In this position, we just flex the. We place a kidney rest under this iliac fossa. To the same like in the prone flex position, we just increase this surgical field, and the supra 11th puncture will become a 12th, supra 12th puncture, and supra 12th become a subcostal puncture, because the surgical field will widen by this flexion. What are the different physiological concern in lateral position? Hemodynamically, there is not much difference in lateral position from the supine or the prone position. But the main concern is when the patient is under general anesthesia and we are doing the positive pressure ventilation, definitely in lateral position, there will be dependent lung will be compressed because of the mediastinum compressing the lower dependent lung. So the ventilation will be more in this non-dependent lung. And because of the increase this gravity, the perfusion will be more in the dependent lung. So the combined effect will be this part will be over perfused, and this part will be over ventilated. So VQ mismatch will be more when we go for general anesthesia with positive pressure ventilation in lateral position. So that should be kept in mind. Now the another position which is used for Pcnl is the modified lateral BART position. In this position, it's a lithotomy position. The same leg is flexed and adducted. Opposite leg is abducted. There's 45-degree rise is done at the level of the this iliac fossa, and the shoulder is made almost perpendicular to this operating room table. In this position, the uteroscopy and the Pcnl nephroscopy can be done in the same position. That is the benefit of this position. But definitely this requires lots of manipulation like positioning. So this position is very difficult to make in the patient with musculoskeletal deformity. But otherwise, in young adult patient who don't have any problem with the muscles or the joint problem with it, this position can be attained. And in this position, both uteroscopy and nephroscopy can be done in the same position. Another position which is used for Pcnl is supine position. In this position, we use a 3-liter bag of saline or this fluid that is placed below the iliac fossa. This is a modified supine position where the ipsilateral leg is kept extended and the opposite leg is flexed. So uteroscopy and nephroscopy can be done in the same position. Now, as we see that most of the institutes, Pcnl is done in the prone position. Supine position Pcnl was first introduced in around 1998 by the Valdivia Uria et al. The advantages of supine position, definitely the surgeons work comfortably because his nephroscope and that will not be like coming in field with the X-ray fluoroscopy which is used during the procedure. So there is no need to change. Also, there is no need to change the position of the patient during the surgery. So this position is comfortable for surgeon nephroscope handling. Also, there is less risk of from anesthesia point of view. Definitely, a supine position, there are less physiological concerns as compared to the prone position, less chances of nerve injuries and airway compression and lot of working staff, which are all the complications which are there with the prone position are not seen in the supine position. So it is better to allocate in the patient with the high risk factors. Also, this position is good in obese patient because in supine position, the skin to stone distance will be less. So the tract size will be less, and that is a good point because it will cause the less pain and the less mobility in the post-op. In this position, it has been found that the risk of puncturing the colon is less because when we lift the iliac fossa with a little bag, the colon and the kidney are also elevated. So chances of puncturing the colon is less in this position. But the disadvantages are, in this position, surgical field is very small. You have to puncture the, you have to make the puncture in the posterior axial line just behind that part elevated. So the surgical field is very small and the collecting systems are collapsed when patient is in supine position. So we have to distend the collecting system using the contrast before making the puncture so that it will not make a through and through puncture. So that collecting system need to be distended with using the contrast before proceeding for the first access puncture in this position. Also, this position might be not be comfortable by many urologists. So as a traditional approach is the prone position in Pcnl. Now, coming to different type of anesthesia and how to decide which type of anesthesia should be used. It depends upon the age of the patient because not only stones are seen in all age group, like from the children to elderly patients. So it depends upon the age of the patient. In small children, definitely they are uncooperative and they're not familiar with the OT environment. They definitely require general anesthesia. And for elderly patients, they come with multiple morbidities, cardiovascular problems, respiratory problems. In that case, if it is comfortable for the surgeon and the positioning of type of surgery, we can go for the regional. We will definitely plan for the regional anesthesia. Patient preference, that should always be taken care of when we are planning for the type of anesthesia. Kidney functioning, if deranged, definitely we go for the regional anesthesia because it will be having lesser, there will be lesser problems with the drug dose calculations and their metabolism when the functions are deranged. Position for the surgery, which is favored by the surgeon and surgeon expertise. Estimated duration of the procedure, which depend upon the stone size, number, and location. If the duration is more, in that case, the patient, if the patient is in a regional anesthesia and the stones are many and they're it's a long procedure, then the position will become uncomfortable with the patient. In that case, we might plan for the general anesthesia. And the stone is such in the upper pole, the surgeon requires to get in upper pole access. So in that case, general anesthesia is preferred to prevent the pleural injury from the first access puncture. So first of all, we'll discuss the general anesthesia, when to plan and what are its advantages and disadvantages. In general anesthesia, we have a secured airway, and as you know, most of the surgeries in Pcnl are done in prone position. In prone position, if you have a secured airway, that is a good point. And during general anesthesia, we can also control the tidal volume. Like when the surgeon is doing the puncture, first access puncture, we can stop the ventilation for a time being so that we can disconnect the ventilator from the patient and to prevent the pleural injury during the high puncture. And as already told, the surgery is that multiple stones are there, difficult stones are there. The duration is more. In that case, the general anesthesia is preferred. So disadvantages of general anesthesia. Making prone is a patient under general anesthesia requires a teamwork. 4 or 5 people are required, and it's required a proper frame, and different gadgets are used, and a whole team of 4 or 5 people is required. So it's required gadgets and time also. So that will be a problem with the while going for general anesthesia. And if we are doing the prone position Pcnl and general anesthesia, the positive pressure ventilation will decrease the cardiac output, and that can if there is also already decreased output with decreased cardiac output because of the decreased venous return from the venous this abdominal compression, that will be the effect will be compounded. So that will be a concern. Also, all the disadvantages which are seen in the prone position, like pressure point compression, eye loss of vision in the post-op because of the eye bulb compression, these all are with general anesthesia, because in general anesthesia patient is not aware. So there is chances of compression of the pressure points and delicate areas are there in general anesthesia. That is not there in the regional anesthesia. So coming to the regional anesthesia. Regional anesthesia for Pcnl was first described in 1988, and nowadays it's definitely most of the centers it is commonly done under regional anesthesia because of its different advantages. Because it causes less postoperative pain. In general anesthesia, once patient is out of the anesthesia, he requires analgesia. On that, opioids and that the side effect of that there will be there, nausea and vomiting will be there. So in regional anesthesia, there will be less pain in the postoperative period, definitely less nausea, vomiting, and blood loss is also there. Blood loss is also less in case of regional anesthesia. With regional anesthesia, there is recovery is early, and the length of stay of the patient in the hospital is also decreased. Also, when you use when you would do the Pcnl, we keep on irrigating the surgical feed with the saline intraoperatively, so that if the extravascular fluid will get absorbed and can cause the this volume overload and electrolyte imbalances, as we see in the Qrp. So that volume overload electrolyte imbalance can be there in case of Pcnl surgery also. And similar as with the Qrp, you know that this electrolyte imbalance and the fluid overload are easy to diagnose and early to diagnose in the case of regional anesthesia as compared to the general anesthesia. In regional anesthesia, the neurological symptoms, irritability, discomfort will come first, and before the hemodynamic and the respiratory compromise, which are normally the first sign and symptom in the case of general anesthesia. So electrolyte imbalance and the interop complication will be diagnosed early in the case of regional anesthesia. Also, the positioning concerns which are there in case of this general anesthesia is not there in the case of regional anesthesia. What are the disadvantages of regional anesthesia? While making the because most of the time regional anesthesia we plan for spinal anesthesia, and that causes hypotension. So that compound hypotension, like once we make the patient prone, that will also cause the hypotension and compound with the Pcnl. Just a minute. Sorry. Yes. Now coming to the disadvantages of regional anesthesia. As we know that most of the time regional anesthesia we plan for spinal anesthesia because of the rapid onset and the good muscle relaxation and rapid offset of the effect. So we go for spinal anesthesia. In spinal anesthesia there is hypotension. And while making the patient prone from supine position, there is always a small fall in the this cardiac output and stroke volume. So the effect of the two can combine and can cause more hypotension when the patient is under regional anesthesia. So that concern should be taken care of. Another problem is when the procedure is of long duration, so patient discomfort will be more in case of regional anesthesia. And as I already told, if the surgeon want to make a higher puncture, in that case, if the patient is unable to hold his breath with the surgeon puncture time, then it will be problematic for the surgeon also. And there is risk of pleural injury. Different studies have been done which compare the regional anesthesia and the general anesthesia for Pcnl. And they have found, like Merabi and Siraz, they found that the spinal anesthesia is a safe and effective alternative to general anesthesia for performing Pcnl in prone positions. Another study done by this Borzoi et al., they found that this final anesthesia for Pcnl is well tolerated in elderly patients with significant pulmonary disease. And in a study done by this Borzoi, they found that the complication rates are even less with this final regional anesthesia as compared to general anesthesia when the Pcnl done under regional anesthesia. Now, a little bit about the surgical complication which may arise during the Pcnl surgery. So we should know what are the complications which can arise and their timely diagnosis and management in the intraoperative period. First of all, pleural injuries that can be there because of that when we do the first access puncture, that the pleural injury can be there, which can present as a pneumothorax, hydrothorax, or hydropneumothorax. The incidence of pleural injuries are around 0.3 to 1%, and it is seen that it is more common on the right side. And when the surgeon get a higher puncture, like supracostal puncture is there, the chances of injury, pleural injury are more. So better to go for subcostal puncture, or definitely hold the breath. Patient should hold the breath if he's awake, or you should disconnect the ventilator at a time of first access puncture to prevent these pleural injuries. And how we will diagnose this pleural injury? Definitely, it will take some time, the pneumothorax and hydrothorax to develop. Once it's developed, in case of awake patient may complain of discomfort, and with the general anesthesia, rising airway pressure can be there. Tachypnea, in awake patient, tachypnea will be there. In the general anesthesia, high airway pressure will be there, and desaturation could also be a presenting sign for the pleural injury. So that may require 100% oxygen along with the chest tube insertion for that complication. Another complication is hypothermia and electrolyte imbalance because of the fluid overload. So whenever we are doing the intraoperative period, we should be very vigilant to see any discrepancy with the irrigation fluid. That is what is going inside the which is going inside the surgical field, that should come out. If there is discrepancy is more, then we should always be vigilant that there is some absorption from in the surgical field and or extravasation from the collecting system. The collecting system injury is there, so that should be ruled out and managed adequately. Sign and symptoms will be the same as the case of this Qrp. The patient may complain of discomfort and uneasiness, followed by there may be hypotension or hypertension, and finally there may be ECG changes and desaturation also when there is fluid overload. Acute anemia, same with the Qrp. There is because of the irrigation fluid, there is a bleeding is going on, and we can't assess the actual blood loss. So patient may have severe anemia before we can diagnose it. So we should be vigilant about that. Another important concern is when you break the stone and there is release of bacteria from that side, and that bacterial endotoxin can release from the stone breakdown, which can cause fever and sepsis. And it has been found that around the incidence of fever is around 30% in the postoperative period, and septicemia is around say 7 or 8%. But even after before proceeding for Pcnl, definitely we will rule out the UTI. Even after ruling the UTI, it has been found that the stone infection can be there in around 25% of cases, and that will be the cause of this septicemia and fever in the postoperative period. So in the postoperative period, if the patient develops fever, septicemia, broad spectrum antibiotics should be started as early as possible to prevent the this septicemia and organ damage, which is a major cause of this morbidity and mortality in this Pcnl patients. Another is a risk of injury to the solid organs, like hepatic or splenic injury can be there because of the puncture. During the puncturing, the injury can occur to the surrounding structures. So in that case, mostly the conservative management is done. And while in the case of gallbladder injury, if it is there, then definitely the surgical management is required. And depending on the time of the when you diagnose that complication, that will decide your type of surgery, like laparoscopic cholecystectomy or open cholecystectomy, depend upon the what stage will you diagnose that the colon this gallbladder has been injured because of the this uterus this puncture injury. And also there is risk of injury to the colon perforation can be there. And Also, the great vessel injuries can be there. Mostly the bleeding from the during the PCL is from the kidney renal parenchyma, and mostly it is managed by the tamponade effect of the this nephroscope. But in case the injury is such, it is in the pelvic region, because the pelvic region there is a high vessel area is there. Also, the parenchyma is less there to compress that to get the tamponade effect. So bleeding from that area will be more. And in that case, you may sometimes require angiomyelization and all that. Now, in the last, a few words about pain during the PCnL surgery. We know that it is a minimally invasive surgery, but it is not painless. So the pain during the PCnL is both visceral and this somatic, visceral or the somatic origin. So pain can arise from the tract, the pericardial tract, which have created from the parenchyma, from this skin to the this collecting system. It can be from the autonomic nervous system, nerve pain can be there, or low back pain from the nephrostomy tube itself. So various methods can be decreased, had been innovated to prevent this pain during the PCnL. First of all, they tried to decrease the size of that incision, like mini Perk technique we are used. Second thing is we can go for the smaller size nephrostomy tube, or even tubeless nephrostomy has been advocated to prevent the postoperative pain, because this nephrostomy tube, which is left in space in the postop, is the main cause of back pain in this postoperative period. Another techniques are, these are the techniques. We can reduce the size of nephrostomy tube. We can go for tubeless nephrostomy, and different analgesic, opioid analgesics, and patient control anesthesia can be given. Another is we can go for different type of thoracic blocks, like paravertebral block, the spinal block, quadratus lumbar block, or the intercostal nerve blocks to decrease the postoperative pain after the PCnL surgery. In the last, just a few words, about a case which we faced. Like, this is a case of 47-year-old male. He was a case of known case of ischemic heart disease, and he had a left-sided renal stone in the lower calyceal system, 18 by 14 millimeter in size. So because the size is around 2 centimeter and it was in the lower calyceal system, PCnL was planned for this patient, and on his echo, the ejection fraction was around 30 to 35%. Another important finding is the patient was also having a difficult airway with MPG4 and irregular detonation and short neck. So definitely we planned, like, because of the decreased cardiac output, spinal anesthesia is not a good technique in this patient. So we planned this, we get this case done under epidural anesthesia. What we did, we put a epidural catheter in the sitting position, and just by going the test dose and just confirming that the epidural is in proper place, we make the patient prone in awake position only. Patient himself or himself position himself in the prone position. So there was no positioning concern in this patient. After making the prone position, we give a graded epidural, like 5 mm boluses of epidural top-up was given about 2 times, and around 9 ml with the 9 ml of drug. The patient, we get a desired level of block for the surgery, and surgery was done uneventful. So like initially, when the regional anesthesia was planned for this PCnL, it was done under epidural anesthesia. But nowadays, we mostly see that because of the less time is required and the fast onset, spinal anesthesia is planned for PCnL. So this is also a good option if the patient is cardiacally, like cardiac compensation, this decompensated patient is there, and we don't want to go for GA and general anesthesia, we can go for epidural anesthesia for this like prone position PCnL. And with this, I'd like to thank you for like patience hearing. And this is my few words just to summarize what are the points which should be kept in mind. To determine the type of position, this depends upon the surgeon experience and its preference. And in obese patient, definitely we prefer little position. For complicated and prolonged anesthesia, prolonged procedure, general anesthesia is preferred. For uncomplicated procedure, an expert surgeon, regional anesthesia is preferred. PCnL, although minimally invasive procedure, but it is a not painless procedure, and it also have many life-threatening complications. So we should be vigilant to diagnose and manage these surgical and anesthetic complications and manage them properly. Thank you very much.
Thank you, Dr. Mamta, for such a comprehensive coverage of the topic. It was a really nicely covered talk. Now the topic is open for discussion. Any questions? Okay, Dr. Mamta, you last the case scenario which you discussed. What was the level in which you had put the epidural catheter was inserted? At what level did you insert the epidural catheter?
Ma'am, it was in the lower thoracic region. 8-9 was like clinically, definitely we can't be sure that it is 8-9, but
definitely
scapula point in, definitely. We
No,
planned
no
around
thrust.
8 to 9. No, 8 to 9 T8, 8 or 9 level we planned from the clinical endpoints only. And after making the patient prone only, we get epidural top up. 3 ml bolus 3 times were given, our 5 minutes differences. And there was no hypertension and no intra-operative compromise in this patient. Surgery was uneventful in this case.
Very well managed topic.
Thank you.
Thank you, Dr. Mamta.
Thank you, ma'am.
Is Dr. Vasudha around? Dr. Vasudha?
So, ma'am, yes, I'm there, ma'am. So, any more questions, any more queries from other people? No. So I would like to thank our esteemed and honorary chairpersons, Dr. Suresh Kumar Singhal sir, and Dr. Kirti ma'am, and Dr. Sunil Sethi sir, for a great discussion on anesthesia for urologic surgeries. And I would like to thank our speakers, Dr. Vineet and Dr. Mamta Jain, for such an informative talk on anesthesia for TURP and Pcnl surgeries respectively. Both the topics were dealt extensively and covered thoroughly, and it was a very nice and informative session. And I would like to thank all the colleagues who spared out their time for this academic session, and I hope they would not be disappointed and would be very happy with this session. So thank you all and have a great evening. Thank you so much.
Thank you, Dr. Vasudha.
Thank you.
Thank you, ma'am.